of how hormones are produced, how they are acting, and how they have unique features in terms of action from that perspective. And we also discussed what can cause different endocrine disorders in that regard. So today we'll continue that, and we'll use case scenarios to highlight that aspect as well, which is there. So we talked about the transport proteins. Now there could be a problem of sensing. Now every hormonal action has to be sensed by the producer to see whether we have got a good effect or not. Classical example, as I said, beta cell, ATP is the signal, but then most ATP is coming via the glucose. So what's happening? Glucose goes inside the cell using GLUT2, GCK, and then glucose 6-phosphate, and we know how it produces the ATP. Now, is GLUT2 insulin dependent? You want GLUT to be insulin dependent or not? So what will happen? You produce more insulin, GLUT2 is more glucose goes in, more insulin, you will die of hypoglycemia. So GLUT2 is insulin independent. It is only going to depend upon your plasma glucose levels. High glucose, more glucose goes to the pancreas, and less glucose goes inside. GLUT2 is what? An active transporter or a passive transporter? It's a passive, so it's a diffusion. But it may be enhanced, GLUT1, and all those things may be enhanced via the insulin. So that is one. Now, what is unique about glucokinase? No. There are two kinases for glucose, hexokinase and glucokinase. So what is the difference between the two? So hexokinase is in all cells, glucokinase is in beta cell. So what is the advantage?
The concentration dependent reaction. Because concentration is higher, so the Km values will be different. So if glucokinase should have a higher sensitivity to glucose.
So only when the glucose goes above a particular level, let's say 80, 90, then you want insulin to come. So that is why evolution has developed a special mechanism in the pancreas. So if the level is low, your hexokinase is also working. But if level is high, glucokinase starts working in that regards, and that becomes important. So the pathway is basically through the glucokinase and the potassium channel from that regards. Now, if you have a activating mutation in the glucokinase, body is sensing my glucose is very high, let's produce more insulin, this is going to cause hypoglycemia. If you have an inactivating mutation, again the potassium ATP channel will be affected and you will have diabetes. And this is what is known as MODY2, which is the mildest form of monogenic diabetes, in which only the fasting glucose is high. So this is a sensing defect. The body is not able to sense that. So 10-day-old neonate with hypoglycemia, weight is 2.9, GIR is 12, richer, ketone is negative, reducing substance is absent. So what is your likely diagnosis? High GIR, non-ketotic, no reducing substance. So hyperinsulinism will be a number one possibility. Growth hormone cortisol is normal, insulin is detectable. So this is looking like a hyperinsulinism because of a GCK defect which can be there. 12-year-old girl, high sugars on routine testing. Blood sugar fasting is 130, 2-hour reading is 144. How do you interpret it?
Fasting because with normal 2-hour reading.
Not normal.
Pre-diabetic,
Yeah.
not bad average.
Yeah.
So more in favor of GCK kind of defect.
Why?
Routine testing.
No. So why does it favor GCK defect?
Because the fasting is only highs.
So wherefore I'm asking, what is the reason?
Reason is if the GCK is there is activating mutation. So the when levels are glucose levels are higher.
Activating mutation.
In GCK, inactivating mutation, what happens if after a certain point of high glucose, the GCK starts acting actually, and that causes postprandial decrease.
So there is a rightward shift for the glucose insulin pathway. So if you and me start secreting insulin at 90, they may start secreting at 120. So that is why their fasting is high. But once the level reaches above 120, 130, they kick in, and that's why the delta, the classical definition is less than 4 millimoles per liter, or the gap is less than 72. Then you start thinking of a GCK problem. So this is very narrow band. And what you will get in this case is HbA1c will always remain normal. There will be a family history, and you will see every generation they'll be there. Like we had that girl who had all the mother and all the maternal aunts, they all had same 6.5, 6.6, 6.7, and they never needed any treatment. The only time where they may need treatment is during pregnancy if the child is unaffected. If the child is also affected, doesn't matter. If the child is unaffected, they may have a need for treatment, because then they will develop macrosomia in that regard. So family history of mild diabetes, this is your classical problem in the glucokinase sensing. So what I'm trying to say is that it's not just the gland, it's not just the hormone. Any problem can happen in the whole pathway. So there is a sensing defect here in that regards. Another very important sensing is the calcium sensing receptor, and this calcium is basically sensed by the calcium sensing receptor, which is at multiple regions. Major expression is in the parathyroid. It tells to the parathyroid, okay, I am more, now you shut down the PTH secretion. It acts on the kidneys to say, now we want the calcium is more, you take off in the urine. So calcium levels become high in the urine. So if you have an inactivating mutation, Nimisha, what will happen?
Calcium will not be detected.
Yes.
It will be high with calcemia and
So your PTH will become more. You will have hypercalcemia with hypocalciuria. So this combination in endocrinology is always important. High blood, low urine. So this is classically not fitting the picture, calcium sensing receptor defect. If you have a activating mutation, you will have
hypocalcemia
with hypercalciuria. So this is your classical scenario. Now, this can it happen in the older age group also. So a person was fine, but now develops hypocalcemia with hypercalciuria at 15 years old. What could be the possible cause? Can it be acquired also? Vibha? If you have antibodies. So if you have a blocking antibody or an activating antibody which comes into the picture, that can cause, like insulin that you were talking about, insulin antibodies, same way this can work. So if they have a blocking antibody, you will develop hypercalcemia. If you have activating antibody, you will develop hypocalcemia. It's in fact an important cause of autoimmune hypoparathyroidism. It is not all because of destruction, but also because of the antibody acting on that particular. So antibody acting can also cause both inactivating and activating picture. So 12-day-old girl Richa with irritability, dehydration. So if you have a sick child who has dehydration and polyuria, what are the things you will think of? Somebody who is dehydrated should have a urine output, which is, but if the urine output is more, what does it mean? That urine is driving the dehydration, so causes decay, adrenal insufficiency, tubular necrosis, and hypercalcemia. So this is a sidewise, but otherwise dehydration with polyuria, very few causes have to be there. Calcium is 18, extremely high. PTH is also high, so there is hyperparathyroidism. But the urinary calcium is not high. What does it mean? So there is a inactivating mutation, and because mutation is in both alleles, that's why the child is presenting as a very severe scenario, because both parents had milder disease. So if you do the urinary calcium and calcium in the parents, it will be like 10 calcium serum, and hypocalciuria. So this is a autosomal recessive form of calcium sensing receptor defect presenting with severe hypercalcemia and hypercalcemic crisis. This is the classical manifestation because of the calcium sensing receptor or neonatal severe hyperparathyroidism. If you get the gene from the mother, what will happen to the child?
You have to see for whether child is affected also.
You're getting the gene from the mother, so obviously child will be affected.
Mild hypercalcemia can be.
So you will not detect it.
Uh,
If you get it from the father,
then severe, but the transient, a severe form of.
so it will be less severe, not 18, but maybe 14, 15, because for this child, the mother's normal calcium are low because there's a problem in sensing. So in response to that, the parathyroid is hyperactive. As soon as they are born, you will have hypercalcemia, which will improve over time from that regards.
Even it is getting from the mother, the heterozygous defects can also cause this mild hypercalcemia.
Mind which you will not detect. So because mother and was never detected, they will behave like so how is this?
FBH kind of thing.
So FBH is detected only on routine screening. So you will not have any symptom. But if you get from the father, the symptoms will be significant.
Sir, is there any bony resorption or something like in case the child get from the father?
They would of course be bony because hyperparathyroidism bone will always be recovered.
It will not that figure like NHSP, but
Yeah, so even with NHSP, they don't develop fractures and all. Their major presentation is they will die because of hypercalcemia rather than fractures. So they will be low bone mass, but the calcium is the major problem. That you need to understand. So unlike adult onset hyperpara or older age where its main work is slowly it is eating a bone and then you have hypercalcemia, there the calcium is will going, the person is going to die. Like calcium plays a vital role in blood clotting. Have you ever seen anybody die because of bleeding disorder because of calcium? Why?
already
Because the level is very low. By that time, the heart will fail. By that time, the seizure will happen. So the amount of bone loss will take time. It is not going to happen immediately because at birth nothing is there. Mother's calcium, everything is fine, and after that you have the problem. So the effect will be because of hypercalcemia. So they will die because of that before anything happens to bone. But of course, when you have hyperparathyroidism, bone will become less. There is no confusion on that. 8-year-old girl with cramps, Nimisha, calcium is 7.6 on the lower side. Phosphorus is high, PTH is low. So diagnosis is so hypoparathyroidism. You will start treatment with why will you look at vitamin you why will you look at vitamin? Because PTH, if it is vitamin D deficiency, PTH should be high. So this is hypoparathyroidism, assuming that the PTH is done properly. So how will you treat this person? You will give them calcium and parathyroid. How do we treat this? So you will give activated vitamin D and calcium. That is the standard treatment. Now, as soon as the treatment was started, the child developed irritability, polyuria, and dehydration. Now, polyuria, constipation, irritability, dehydration, they are markers of hypercalcemia or more specifically, hypercalciuria. So, polyuria is because of there's too much calcium. And when I talk about, I think calcium, we discuss about that, how calcium sensing receptor plays a role in the renal reabsorption process. So if you have hypercalcemia, or more precisely, if your calcium sensing receptor is hyperactive, you will develop polyuria. So develops polyuria, what do you think was wrong in this case, or what should have been done beforehand? So even with a small dose, he developed, and calcium is not high. Calcium you check was normal, but still there is polyuria. So what type of hypoparathyroidism is this? So this could be a sensing defect. So it could be a calcium sensing receptor defect. They already had some hypercalciuria. On top of that, you gave them more calcium, and that is why this hypercalciuria is going to become much more significant. So before you start treatment of anybody with hypoparathyroidism, check their urinary calcium. Everybody with hypocalcemia should have zero urinary calcium. If you have hypercalciuria, then this is a calcium sensing receptor defect. So this is something to remember. Now, if I just want to compare that, you have got 4 types of patients. One has got hyperparathyroidism. The other patient has got hypoparathyroidism. and the third one has got a calcium sensing receptor defect. Somehow you are able to get all their calciums to 12. Who will have the maximum urinary calcium and who will have the least urinary calcium? So hyperparathyroidism, hypercalciuria is there or not? Yeah. Yes, but if you get their level is 11, your hypoparathyroidism level also you have got to 11, and the calcium sensing receptor you got to 11. Who will leak the most calcium? Yes. Second, hyperpara will actually conserve because PTH is conserving calcium. But your calcium is too much, that's why they develop hypercalciuria. So what you need to remember is that for the same level of calcium, calcium sensing receptor will have the maximum hypercalciuria and nephrocalcinosis. So if you want to avoid that, what treatment could be good one, Vibha, in that regard? Avoiding hypercalciuria. Thiazide, okay. Anything else specific in that scenario? Hypoparathyroidism. Primarily the problem is hypoparathyroidism. So you can give something which conserves urinary calcium. Or PTH? You give PTH, that is the best. So PTH, if one indication you want to treat for childhood hypopara, that will clearly be calcium sensing receptor defect. Because even if you keep their calcium at 8, 8.5, they will develop hypercalciuria. So calcium targets in calcium sensing receptor is 7.5 to 8. Hypoparathyroidism is 8 to 8.5. And pseudo-hypoparathyroidism is 9.5 to 10. You want to keep them high. So this is something to remember. You don't want to go to calcium to be very high. Otherwise, they will develop nephrocalcinosis from that regards. So this is an autosomal dominant hypoparathyroidism or a calcium sensing receptor defect.